In this video, I'm going to teach you how to perform a respiratory system examination. There's 6 things you need to know. 1. When to start thinking about the diagnosis. Number 2. Preparation. 3. End of bed observation. 4. General examination. 5. Chest examination. And 6. Pathological classification framework, so you don't miss anything important. 1. When to start thinking about the diagnosis. As soon as you enter the ward and start to examine the patient, you should already be thinking about possible diagnoses. For example, if the patient is around 40 years old and has chronic respiratory complaints, then COPD is a strong consideration. You must look around the ward for clues. Is the patient using oxygen? Are they on a ventilator? Do they have any inhalers, nebulizers, CPAP, BiPAP, or any chest drainage bottles? Start thinking about the patient's management. What are their medications? Are they an ex-smoker? What about their lifestyle? It is really important to try to form a broad differential. Then start to narrow this down. Think about complications too. Is there any signs of right heart failure or lower leg swelling? Think about the possibility of fluid overload. COPD often coexists with OSA or obesity hypoventilation syndrome, both of which can cause CO2 retention and respiratory acidosis. OSAT is more common in men, but also affects women who tend to gain weight post-menopause. Consider acute on chronic respiratory failure. Is there a history of recent respiratory infection or chest pain? These would suggest a secondary cause such as pneumonia, pulmonary embolism, pneumothorax, or pulmonary hypertension. As I said, our job is not only to make the diagnosis but to also think beyond it. We need to anticipate management, complications, and comorbidities. Number 2. Preparation. Wash your hands and introduce yourself to the patient. Explain what you are going to do, the purpose of the examination, and how long it should take. Ask for consent. Tell the patient what to expect and ask them to let you know if they feel any pain or discomfort, and you will stop. Always allow the patient to call you by a preferred name and ask how they would like you to address them. It's very important to put the patient at ease. Reassure them that you are there to help them and that you will answer any questions they may have. Now the next step is exposing the patient adequately. The aim here is to expose the chest from the clavicles to the castal margin, including the back, so we can palpate and percuss the whole area. Make sure you protect the patient's dignity. Ask the patient to lift both arms away from the body and place the towel under the chin and over the top. Now turn the patient onto their left side. Use your hand to hold the towel away from the patient. Now use your other hand to carefully roll the patient onto their back. Once the patient is positioned correctly, quickly drape the patient with the towel and expose the chest. Remember, we need to examine the entire chest wall, including the back. Repeat the same steps on the other side. Drape the patient appropriately throughout the examination. 3. End of bed observation. This includes general appearance, body habitus, scars, and special bedside trick. Now the general appearance is assessing the patient's state of health, looking for signs of respiratory distress and altered consciousness. Is the patient speaking in short phrases? Are they using accessory muscles? Any nasal flaring, adventitious sounds, cyanosis, or abnormal breathing pattern? Next is the body habitus. How does the patient lie in bed? Does the patient have any accessory muscle use? This will help us predict certain diseases. A patient who appears thin and cachectic might have an underlying malignancy or advanced COPD. However, obesity can be associated with O's and OS. A patient who looks obese but is very breathless with minimal exertion could have underlying O's or O's. Now, my special bedside trick. After inspecting the chest and before getting to the bedside to examine the patient, ask the patient to take a deep breath through the mouth while you re-still at the foot of the bed. This helps me to detect abnormal breathing patterns early on, such as paradoxical breathing, where the abdomen moves inwards on inspiration, suggesting underlying pathology such as neuromuscular disease or pulmonary hypertension. It can also strongly suspect the diagnosis. However, I always complete the full history and examination before making a diagnosis. Now, moving on to the scars. Note the number, location, and size of the scars. Is there any thoracotomy scars or chest tube sites? Are there any radiotherapy tattoos? Some scars can give us a clue to the diagnosis, such as a scar on the left lower chest wall. This can indicate a previous lobectomy for lung cancer. Moving on to chest deformities. There are 3 main types of deformities you need to look out for: barrel chest, pectus carinatum, and pectus excavatum. Barrel chest is the most common deformity seen in respiratory medicine. This occurs when a patient has emphysema. It makes the patient look like they are suffocating. Pectus carinatum is known as a carrying chest, and pectus excavatum is known as an excavated chest. Deformities can affect lung volumes, making the patient breathless. Also, kyphoscoliosis can make the patient look abnormal. Take note of any audible signs from a distance. Do you hear any wheeze, crackles, or altered breathing sounds? Wheezing suggests airway obstruction. such as asthma or COPD. Coarse crackles may suggest secretions or bronchiectasis. Fine crackles may suggest fibrosis or ILD. Swelling may be present on examination. Look out for facial or neck swelling, which can be caused by SVC obstruction. Also check for lymphadenopathy. Moving on to the trachea. Look at its position. Is it midline? Any deviation in the neck, look for lymph node enlargement. This can be caused by TB or metastasis. Number 4. General examination. Before examining the chest, look at the hands for clubbing. This can be seen in lung cancer, bronchiectasis, or ILD. Look at the palms for peripheral cyanosis. Ask the patient to extend their arm fully. Turn the palm upwards and check for central cyanosis in the conjunctiva and nail beds. Look for flapping tremor. This is a type of involuntary movement that can occur in patients who are CO2 retaining. Next, check the pulse. Is it regular? What is the rate? Is there any edema? Check the respiratory rate. Observe this quietly without alerting the patient. Remember, our aim is to collect as much information as possible without raising suspicion. Moving on, look for muscle wasting, especially the small muscles of the hands. This can be seen in Pancoast tumor, which affects the brachial plexus. When examining the face, look at the conjunctiva for pallor, which can indicate anemia. Check for central cyanosis. Look for Horner's syndrome, which can be caused by SVC obstruction or Pancoast tumor. Inspect the neck for tracheal deviation. Does it suggest loss of volume or shift away from excess volume? Is there any lymph node enlargement? Number 5. Chest examination. Now, we're going to examine the chest using the 4 techniques: inspection, palpation, percussion, and auscultation. During palpation, check the trachea again and note the position and the cricosternal distance. Palpate the apex beat and note its location. Does it suggest a shift in hyperinflation or volume loss? Assess chest expansion. Does it move symmetrically? Any restriction of movement? Palpate the chest wall for any abnormalities or masses. Remember, tactile vocal fremitus can be assessed during palpation, but this takes additional time. Moving on to percussion. Start by comparing side to side, including the clavicles, axillae, and posterior bases. Note the predominant note. Dullness suggests consolidation, collapse, fibrosis, or tumor. Stony dullness suggests pleural effusion. Hyperresonance suggests pneumothorax or severe COPD. Remember, in COPD, the dullness of the cardiac and hepatic areas is lost due to hyperinflation. During auscultation, listen to the breath sounds. Are they vesicular or bronchial? Any prolonged expiration. This can suggest COPD or asthma. Added sounds include wheeze, crackles, and pleural rub. Wheeze suggests airway obstruction. Coarse crackles that change with cough suggest bronchiectasis. Fine Velcro crackles that don't change with cough suggest fibrosis. Pleural rub suggests early pleurisy. During vocal resonance assessment, speak into the part of the stethoscope. You are not listening through, and listen for any increase or decrease in sound. An increase in sound suggests consolidation, and a decrease in sound suggests effusion or pneumothorax. No. 6. Pathological classification framework. This is my mnemonic, KSI, to help you remember the main categories. You should consider collapse, consolidation, hyperinflation, bronchiectasis, and fibrosis. 1. The reduction group, which includes pleural effusion, knee pneumonectomy, lung collapse, and peripheral bronchial obstruction. If the whole lung has collapsed, it will behave like an effusion. If a segment of the lung has collapsed, it will behave like consolidation. A peripheral bronchial obstruction can sometimes mimic collapse. 2. The consolidation group, which includes pneumonia, lung cancer, and pulmonary infarction. These can cause dull percussion, bronchial breath sounds, increased vocal resonance, and possible crackles. 3. The hyperinflation or obstructive group, which includes COPD and asthma. Features include prolonged expiration, hyperresonance, loss of cardiac and hepatic dullness, and quiet breath sounds with widespread wheeze. 4. Bronchiectasis causes coarse crackles that change with coughing, chronic purulent sputum production, and is sometimes associated with clubbing. 5. Fibrosis can be localized and mimic consolidation, or be more diffuse with fine Velcro crackles that do not change with cough. Sometimes patients have both fibrosis and pneumonia, and therefore you'll see a mixed picture. Remember, physical findings in ILD can be subtle. Therefore, you should always check oxygen saturations and do a peak flow or spirometry. Also request a chest X-ray and arrange for a sputum analysis. An arterial blood gas should be performed if hypoxia or hypercapnia is suspected. So those are my tips on performing a respiratory system examination. Please let me know if you found it helpful. Don't forget to subscribe.